Welcome to this video entitled, Miliary Tuberculosis in Critical Care. We will begin with an introduction. In the developing world, tuberculosis, TB, continues to be a major cause of morbidity and mortality. In industrialized countries, TB has essentially become a public health issue. While diagnostic and therapeutic issues remain, disease in most cases is not threatening enough to warrant admission to the critical care unit. Miliary TB, however, is often rapidly fatal, providing a diagnostic and therapeutic challenge to even the most skilled intensivists. The term miliary was first introduced by John Jacobus Mangett in 1700, when he likened the multiple small white nodules scattered over the surface of the lungs of affected patients to millet seeds, as shown in Figure 1. While miliary TB was initially an anatomic and later a radiologic term, it now denotes all forms of progressive, widely disseminated TB. Synonyms include hematogenous TB, generalized TB, disseminated TB, septic TB, and Landuzzi sepsis. As a disease entity, miliary TB is not due to infection with particularly virulent pathogens, but is generally precipitated by host issues. Affected patients are typically predisposed by a weakened immune system, most notably defects in cellular immunity, resulting in the unchecked lymphahematogenous dissemination of Mycobacterium tuberculosis. The development and widespread use of more potent immunosuppressive agents, as well as the emergence of HIV/AIDS in recent years, have resulted in an increased proportion of TB cases presenting with disseminated disease. We will now discuss the epidemiology of miliary tuberculosis. Estimates for incidence and prevalence rates are often based on convenience samples, as population-based data are not available. Autopsy and hospital-based case series, however, generally suffer from selection and allocation bias. A large Boston City Hospital series collected in the pre-antibiotic era found that 20% of all patients with TB had evidence of disseminated infection at autopsy. In the 1970s, another study from Boston City Hospital found that only 0.4% of patients with TB had a miliary disease pattern. Since the advent of the HIV epidemic, most case series have reported that miliary TB accounted for approximately 1% to 2% of all cases of TB and 8% of all cases of extrapulmonary TB. Rates as high as 38%, however, have been reported in case series from hospitals with high HIV case rates. In the 2006 surveillance report from the Centers for Disease Control and Prevention, CDC, 1.8% of all cases of TB were classified as miliary. In general, the incidence of miliary TB in a given institution is going to depend on the rate of TB in the population served and the proportion of patients with increased risk for dissemination. We will now focus on the pathophysiology of miliary TB. Predisposing conditions. Age and predisposing medical conditions, Table 1, are the most significant risk factors for the development of miliary TB. Miliary TB, however, should never be excluded from the differential diagnosis merely because a patient has no underlying medical illness. In all large case series, a significant percentage of patients have no demonstrable high-risk condition for dissemination. Race, ethnicity, and gender can affect TB demographics, but appear to have little effect on the proportion of patients presenting with miliary TB. We will now focus on age. In the pre-antibiotic era, miliary TB was predominantly a disease of infants, children, and adolescents. Due to the delayed development of the cellular immune system, children under the age of 3 years are at highest risk for progressive disease. While TB nowadays is rare in infants, the proportion of TB patients presenting with disseminated disease is still higher than in any other age group. In a series from South Africa, Miliary TB accounted for 8% of hospital admissions for TB in children compared with 1% in adults. More than 50% of such cases occurred in children under the age of 1 year. Reports from the early 1970s indicated a progressive shift of the epidemiology to adult populations. In an autopsy study conducted at a hospital in Northern Ireland, 54% of patients diagnosed with Miliary TB between 1946 and 1949 were less than 20 years of age. In a latter era, that is 1966 till 1969, all patients with Miliary TB were aged over 30 years. The widespread use of BCG vaccination has resulted in substantial reductions in Miliary TB among young vaccines. The increasing uses of modern radiologic and invasive diagnostic methods have also contributed to the demographic shift. While infants remain at high risk for the development of Miliary TB, the majority of cases now occur in adults. In accordance with the current population distribution of TB and the growing population of older adults presenting with age-related waning or iatrogenic impairment of cellular immunity, the elderly have now become the most common group to develop Miliary disease. In a study from Scotland, the mean age of patients with Miliary TB was 59.3 years during 1954 till 1967, but was 73.5 years during 1984 till 1992. The HIV, AIDS pandemic and an increasing number of patients with iatrogenic impairments of cellular immunity have led to an additional peak of Miliary TB among younger adults, resulting in a biphasic epidemiologic curve. Next we will discuss underlying medical conditions. Mycobacterial virulence factors and host immune defenses determine the risk of dissemination. In large studies, 30% to 80% of patients with Miliary TB had underlying medical conditions, as shown in Table 1. Tumor necrosis factor alpha, TNF-alpha, plays an important role in the host immune response to TB. Not surprisingly, the increasing use of anti-TNF agents like infliximab and etanercept has resulted in a disturbing numbers of reports of patients suffering from pulmonary and disseminated TB. Pause the video and carefully scrutinize Figure 1 illustrating millet seeds before advancing to the next slide. Pause the video and carefully scrutinize Table 1 summarizing underlying medical conditions before advancing to the next slide. We will now look at immunology. Adequate containment of tubercle bacilli requires an intricate interplay of different components of the innate and the adaptive immune system. Macrophages generally represent the first line of defense. Binding to surface toll-like receptors, abbreviated as TLRs, initiates a robust innate immune response. TLR-mediated signals influence cytokine production and homing of effector T cells to the site of infection. Engulfed bacteria are eliminated by reactive nitrogen and oxygen intermediates. Infected macrophages process and present antigens to various T cell subsets, including MHC class II restricted CD4, T helper lymphocytes and MHC class I restricted cytolytic CD8, T suppressor lymphocytes. Processed peptides and secreted cytokines, including interleukin, IL-12, trigger Th1 cells to secrete cytokines, including IL-2 and TNF-alpha, which in a feedback loop further activate the macrophages. Dominance of Th2-type cytokines, such as IL-4, IL-5, IL-10, increases the risk of dissemination by cross-inhibiting protective responses such as granuloma formation. Additional molecular defects also contribute to an increased risk of developing disseminated TB. These mechanisms include impaired expansion of GDT cells, inadequate CD4 cell function or quantity, the presence or absence of certain HLA phenotypes, impaired MHC class II restricted target cell lysis, and premature lysis of target cell macrophages. Clinical presentation. Miliary TB can arise as a result of progressive primary infection, from reactivation of a latent focus with subsequent spread, or rarely even following iatrogenic infection. Disseminated TB has, for instance, been reported after extracorporeal shock wave lithotripsy, homograft cardiac valve placement, and even catheterization of the urethra. Transplantation of a solid organ not previously recognized and infected with Mycobacterium tuberculosis can also result in miliary TB. The clinical manifestations of miliary TB are highly variable and often nonspecific. In immunocompromised patients or when miliary TB develops during primary infection, the disease tends to have a more acute onset and follow a more rapid clinical course. Fulminant disease with Landausi sepsis, a systemic inflammatory response syndrome with refractory shock, potentially including multi-organ system failure, and acute respiratory distress syndrome, abbreviated as ARDS, may ensue. The cytokine storm can be quite dramatic and result in a clinical picture resembling gram-negative septic shock. These complicated cases are typically the patients encountered by critical care providers. Reactivation miliary TB can present as an acute illness as well, but is more likely to be subacute or chronic. Reinfection may have a role in highly endemic areas. At the chronic end of the spectrum, presentation with prolonged fever of unknown origin, anorexia, weight loss, lassitude, night sweats, and cough are frequent. In one series of 38 patients, the median duration of illness reported was 2 months. Rarely, especially among older people, apirexial presentations with progressive wasting strongly mimicking a metastatic carcinoma are seen. This is occasionally described as cryptic miliary TB. Rigors are unusual but have been described. Paradoxical worsening of lesions during effective TB therapy is known as immune reconstitution disease, abbreviated as IRD. While immune reconstitution disease is distinctly rare in HIV-negative individuals, almost 1/3 of patients with HIV per terabyte co-infection experience some form of immune reconstitution disease within days to weeks of the initiation of highly active antiretroviral therapy, abbreviated as HAART. Manifestations include fever, appearance or worsening of lymphadenopathy, new or worsening pulmonary infiltrates, serositis, cutaneous lesions, and new or expanding CNS tuberculosis. Atypical presentations and the nonspecific symptomatology can delay the diagnosis and account for the fact that this diagnosis is frequently missed, even in the current era of improved diagnostics. In a recent review, approximately 20% of reported cases of miliary TB in the United States were diagnosed post-mortem. We will now look at organ manifestations. At autopsy, organs with high blood flow, including lungs, spleen, liver, bone marrow, kidneys, and adrenals, are frequently affected. Most organ system afflictions remain subclinical. Concurrent, clinically apparent pulmonary disease is present in more than 50% of patients with miliary TB. Respiratory symptoms, cough, dyspnea, pleuritic chest pain, are present in 30% to 70% of patients. Hypoxemia, when looked for, is common and may progress to acute respiratory failure and ARDS. Gastrointestinal tract involvement is seen in 10% to 30% of patients with miliary TB. Commonly reported symptoms include abdominal pain, diffuse or localizing to the right upper quadrant, nausea, vomiting, and diarrhea. Liver function tests are frequently abnormal and typically suggest a cholestatic pattern. Frank jaundice, ascites, cholecystitis, and pancreatitis are rare, but elevations of alkaline phosphatase and transaminases were reported in 83% and 42% of patients in one series. Fulminant hepatic failure has been reported. Cutaneous disease is rare except for in patients with underlying HIV infection. The skin manifestations are as protean as the clinical manifestations of miliary TB. The most typical skin lesions, termed tuberculosis cutis miliaris disseminata, or tuberculosis cutis acuta generalizata, are described as small papules or vesiculopapules. Rarely lichenoid, macular, purpuric lesions, indurated ulcerating plaques, and subcutaneous abscesses have been reported. Adrenal gland involvement has been found in as many as 42% of autopsy-based case series. A recent study using computed tomography, CT, found adrenal gland enlargement in 91% of patients with miliary TB. Interestingly, overt adrenal insufficiency remains rare, occurring in less than 1% of reported cases of miliary TB. Central nervous system (CNS) disease, typically presenting as meningitis or brain tuberculosis, is clinically evident in 15% to 30% of patients. Conversely, about 1/3 of patients presenting with TB meningitis have underlying miliary TB. In a small series from India, magnetic resonance imaging (MRI) with gadolinium enhancement revealed asymptomatic brain lesions in all patients. At autopsy, seeding of every organ in the body has been reported. Osteomyelitis, bursitis, and arthritis may be clinically evident. Eye disease is usually asymptomatic but can be diagnostically important. Laryngitis may increase risk of transmission. Even in autopsy series, cardiovascular involvement, with the exception of pericarditis, is distinctly rare. Mycotic aortic aneurysms are unusual but can be the cause of fatal ruptures. Next we will discuss the diagnosis miliary TB. The issue with diagnosing miliary TB is generally not how and where to find the pathogens, as they tend to be everywhere in this disease. The problem is to consider the diagnosis in time and to initiate diagnostic workup and therapeutic interventions without delay, as the host is generally not able to control Mycobacterium tuberculosis without help. As miliary TB can be rapidly fatal, useful diagnostic tests will have to have a short turnaround. Previously, cryptic miliary TB was often diagnosed only at autopsy. However, with the availability of high-resolution computed tomography, abbreviated as HRCT, scans, these patients can now be diagnosed during life. Although miliary TB involves almost all organs, most often the involvement is asymptomatic. We will now talk about laboratory results. Laboratory abnormalities are common in patients with miliary TB. However, no specific patterns of abnormal hematological and biochemical markers have been identified. A typically normocytic, normochromic anemia is seen in approximately 50% of the patients. Most patients have a normal white blood cell count, but leukopenia and leukocytosis occur in an approximately equal minority of patients. A leukemoid reaction simulating acute leukemia can occur. Thrombocytopenia and thrombocytosis have been reported. Pancytopenia due to bone marrow infiltration or a hemophagocytic syndrome has been described. Disseminated intravascular coagulation may accompany septic TB and is associated with a poor outcome. Hyponatremia, the most common biochemical abnormality, often indicates inappropriate antidiuretic hormone secretion. Hypercalcemia and polyclonal hypergammaglobulinemia have been reported in several cases. Bronchoalveolar lavage tends to reveal absolute and relative lymphocytosis, but mostly due to conflicting results, no other useful markers have been identified. As HIV infection is so common in patients with TB, all persons suspected of having active TB should undergo HIV testing. We will now discuss detection of latent TB infection. Tuberculin purified protein derivative, abbreviated as PPD, anergy is more common in patients with miliary TB compared to other TB manifestations. Less than half of all patients with miliary TB will have a positive purified protein derivative. In some patients, tuberculin conversion may occur following successful treatment. Newer in vitro assays have become available that detect latent TB infection based on measurement of interferon gamma release by T cells following exposure to specific MTB antigens. These assays are now commercially available and have been automated. Sensitivity and specificity of these assays appears to be higher than that of the tuberculin skin test, but it is not at all clear how they will perform in miliary TB. Early case reports appear to indicate that these tests may not always be able to confirm latent infection in patients with disseminated disease. We will now focus on imaging. Chest radiograph. The diagnosis of miliary TB is often based on the presence of a classic miliary pattern on chest X-ray, which, according to the recommendations of the Nomenclature Committee of the Fleischner Society, is defined as a collection of tiny, discrete pulmonary opacities that are generally uniform in size and widespread in distribution, each of which measures 2 mm or less in diameter. Figure 2. If present, the faint, reticulonodular infiltrate is usually indeed characteristic enough to alert astute clinicians to consider the diagnosis of miliary TB. There are, however, several problems with relying too much on the radiologic diagnosis of disseminated TB. The typical miliary pattern may only become apparent days or weeks after the onset of clinical symptoms. The initial nodular interstitial spread occurs without significant alveolar involvement. In order to be large enough to be appreciated on a plain chest radiograph, however, some spread to the adjacent alveoli will have to have occurred. Furthermore, while many studies report extraordinary high rates of classic radiologic findings, this usually is a self-fulfilling prophecy, as the radiologic findings were often used as an inclusion criterion as well. Recent studies that did not rely on radiologic criteria for inclusion found the classic X-ray presentation in less than 50% of patients with miliary TB. An additional 10% to 30% of patients have larger or atypical lesions. Asymmetrical nodular pattern, coalescing nodules, mottled appearance, snowstorm appearance, ground glass appearance, and air space consolidation have been described. Conversely, other conditions that typically present with larger nodules, such as alveolar hemorrhage, lymphangitic cancers, or inhalational diseases, can appear as early small nodules. While most of the nodules observed in these diseases tend to be larger and more heterogeneous than classic miliary TB, the overlap may be significant. Approximately 5% of patients have additional findings that may provide additional clues to the diagnosis. Such findings include evidence of intrathoracic lymphadenopathy, pleural effusion, parenchymal lesions and cavitations, thickening of interlobular septa, pneumothorax, pericardial effusion, or other evidence of active or healed parenchymal TB. Subtle miliary lesions are best appreciated in slightly under-penetrated films, but in many cases visualization requires a high index of suspicion and review with an experienced chest radiologist. And now let's consider CT scanning. CT scanning, especially with HRCT, is more sensitive for miliary TB than plain chest radiography. Numerous small, that is 1 to 3 mm, nodules, distributed throughout both lungs, are easily visualized. However, while sensitive, these findings are not necessarily specific. In series correlating clinical and pathologic findings with HRCT, disseminated nodules were also found in many other infections: Haemophilus influenza, Mycoplasma pneumoniae, Candida albicans, and non-infectious diseases, such as sarcoidosis, metastatic adenocarcinoma, lymphoma, amyloidosis, hypersensitivity pneumonitis, and pneumoconiosis. CT-guided needle biopsies may help elucidate the diagnosis, but no data on the sensitivity of CT-guided invasive techniques are available. Pause the video and carefully scrutinize Figure 2 illustrating a CT scan with miliary disease pattern before advancing to the next slide. And now we will discuss the microbiology. Smear and culture examination of expectorated or induced sputum, gastric lavage, pleural, peritoneal, or pericardial fluid, cerebrospinal fluid, urine, pus, bronchoscopic secretions, peripheral blood, bone marrow, liver biopsies, lymph node material, and transbronchial lung biopsy specimens have all been used to confirm the diagnosis of miliary TB, but with varying results. A recent review, however, came to the conclusion that, in the published reports, no systematic pattern of diagnostic approach could be identified, and invasive diagnostic sampling appeared to be arbitrary and individualized, especially in the pediatric series. While it is indeed difficult to generate evidence-based recommendations for testing, recent studies have helped establish several important testing paradigms. Smears for acid-fast bacilli are generally not sensitive enough to rule out miliary TB, as samples at any site were only positive in a minority of patients, as shown in Table 2. However, the probability of a positive smear increased with the number of sites sampled. Thus, when present, samples of sputum, gastric aspirate, urine, pleural fluid, pericardial fluid, and ascites should all be rapidly examined for the presence of acid-fast bacilli. Fluorochrome dye-based stains may be more sensitive than conventional Zeil-Nielsen staining. It should be noted that neither of these traditional stains allows for distinction between tuberculous and non-tuberculous mycobacteria, but direct probes have been developed that allow for species detection in smear-positive samples. Cultures tend to be more sensitive, but the turnaround time of several weeks significantly diminishes their usefulness in the critical care setting. However, even if the results may not be available in time before treatment decisions have to be made, it is extremely important to procure tissue or fluids, as positive cultures are prerequisite for later drug susceptibility testing. Although blood cultures in miliary TB are most likely to be positive in HIV-infected patients, mycobacterial blood cultures are a rapid and minimally invasive method of diagnosis. All specimens should be inoculated into an automated radiometric detection system, preferably using lysis centrifugation techniques, which is both more rapid and more sensitive than standard techniques using solid medium for the isolation of Mycobacterium tuberculosis. Nucleic acid probes have been developed that can differentiate Mycobacterium tuberculosis from commonly isolated non-tuberculous mycobacteria directly from liquid culture media. Pause the video and carefully scrutinize Table 2 summarizing the frequency of positive smear or culture results in patients with miliary TB before advancing to the next slide. And now let's look at rapid testing. Enzyme-linked immunosorbent assays, abbreviated as ELISA, capable of detecting mycobacterial antigens, antibodies, and immune complexes have been used for diagnosis of miliary TB, but the true usefulness of serodiagnostic tests remains to be established. The United States Food and Drug Administration, FDA, has approved several nucleic acid amplification tests, abbreviated as NAATs, for the rapid identification of Mycobacterium tuberculosis in respiratory samples. These tests produce results within 2 to 7 hours after sputum processing and are therefore of interest in critically ill patients. Nucleic acid amplification tests should be performed in biosafety level 2 or 3 laboratories. False positive or false negative results occur more frequently when technician proficiency is suboptimal. While sensitivity and specificity are somewhat dependent on pretest probability, all available tests perform better in smear-positive samples than in smear-negative patients. Not a single study has evaluated the usefulness of nucleic acid amplification tests for the diagnosis of patients with miliary TB. Target amplification using the polymerase chain reaction, abbreviated as PCR, has been more sensitive than standard techniques in some series examining respiratory specimens, bone marrow or liver biopsy specimens, CSF, or blood. Molecular rapid tests have generally replaced adenosine deaminase and interferon gamma-based tests that have mostly been evaluated in resource-limited settings with high pretest probabilities. Although molecular diagnostic tests can support the diagnosis of miliary TB in the appropriate clinical setting, a negative test cannot rule out miliary TB, and treatment or additional diagnostic tests should not be delayed because of negative results. We will now look at histopathology of tissue samples. Histopathologic examination of tissues continues to play an important role in the rapid diagnosis of miliary TB. Liver biopsies have the highest yield. In the 2 modern case series, granulomas were demonstrated in up to 100% of liver biopsies, 82% of bone marrow biopsies, and 72% of transbronchial biopsies. Lymph nodes and serosal biopsies also had high yields in these series. If biopsies were guided by clinical or laboratory abnormalities specific to the organ system being sampled, the yield was generally higher. Specific target amplification can be performed on fresh and even processed samples. While this appears highly promising, data for its use in miliary TB are to be generated. And now we will discuss other tests. If present, choroidal tubercles are pathognomonic of miliary TB. A dilated ophthalmoscopic examination may offer a valuable clue to the diagnosis of miliary TB. Positron emission tomographic, abbreviated as PET, can help distinguish infection from malignant lesions, but it should be noted that 1 to 3 mm lesions may be too small to generate a positive signal. Pulmonary function tests often show abnormalities, but no characteristic pattern have been identified that would increase the diagnostic yield of other studies. And now let's shift gears to the differential diagnosis of miliary TB. The differential diagnosis of febrile illnesses with miliary chest X-ray infiltrates is broad and includes infectious and non-infectious entities. Infectious diseases include other non-tuberculous mycobacterial infections. Fungal infection mostly due to endemic fungi, histoplasmosis, coccidioidomycosis, blastomycosis, O. paracoccidioidomycosis, can mimic miliary TB. Appropriate exposure and travel history may provide important clues. Bacterial infections described in the literature include Legionella infection, nocardiosis, pyogenic bacteria, Staphylococcus aureus, Haemophilus influenza, psittacosis, tularemia, Bartonellosis, brucellosis, and melioidosis. Viral infections, varicella, cytomegalovirus, influenza, measles, and parasitic infections, such as toxoplasmosis, strongyloidiasis, or schistosomiasis, can produce similar patterns. Neoplastic diseases, including lymphoma, lymphangitic spread of various cancers, or mesothelioma, are in the differential diagnosis, as are other diseases including sarcoidosis, amyloidosis, hypersensitivity pneumonitis, alveolar hemorrhage, storage disorders, pneumoconiosis, and foreign body-induced vasculitis related to injection drug use. Next we will look at the treatment of miliary TB. While many patients control TB even without therapy, miliary TB is uniformly fatal if not treated. Even when treated, the mortality related to miliary TB remains about 10% to 20% in children and 20% to 30% in adults. Delay in the diagnosis or initiation of treatment contributes to the high mortality. Currently, there are no randomized trials evaluating the efficacy of different regimens for the treatment of miliary TB. Next we will consider anti-tuberculous chemotherapy. The American Thoracic Society, CDC, and the Infectious Diseases Society of America have issued joint guidelines for the treatment of TB, which address treatment of miliary TB. Based on a number of clinical trials, the guidelines recommend 4 basic regimens for treating patients with TB caused by drug-susceptible organisms. These regimens are applicable to most patients with TB, although modifications are made for specific populations. Each regimen has an initial phase of 2 months followed by a choice of several options for the continuation phase of either 4 or 7 months. The choice of treatment in the initial phase is empiric, as susceptibility data are usually not available or only available at the end of the initial phase of treatment. Susceptibility data should be available at the beginning of the continuation phase and should be used to direct therapy if drug resistance is identified. The initial drug regimen is based on knowledge of the likely drug susceptibility, and 4 drugs are used in the initial phase of treatment when the total duration of treatment is 6 months. The treatment regimen for most adults with previously untreated TB consists of a 2-month initial phase of isoniazid, abbreviated as INH, rifampin, abbreviated as RIF, pyrazinamide, abbreviated as PZA, and ethambutol, abbreviated as EMB. In the continuation phase, treatment is given for either 4 or 7 months and consists, in most cases, of isoniazid and rifampin alone. Most patients will be treated with the 4-month continuation therapy for a total duration of treatment of 6 months. The recommendations for disseminated TB are essentially the same as for pulmonary TB. Since extrapulmonary TB is less common than pulmonary TB, these recommendations are based upon retrospective review of a relatively small number of patients with extrapulmonary TB. While the data suggest that this approach is successful in the era of potent bactericidal regimens, it is important to individualize the regimens in specific circumstances. Longer therapy should, for instance, be considered in certain patients with miliary TB, including children and immunocompromised hosts. The American Academy of Pediatrics advocates 9 months of treatment in their guidelines. In the presence of associated TB meningitis, treatment duration needs to be extended to at least 12 months. In view of the high frequency of TB meningitis in patients with miliary TB, the British Thoracic Society suggests that all patients with miliary TB undergo a lumbar puncture in order to determine the optimal duration of treatment. Patients with lymphadenitis, a large organism burden, and those with a slow microbiologic or clinical response also tend to have a higher relapse rate and may benefit from prolonged therapy, but no evidence-based recommendations are available for such circumstances. The guidelines clearly recommend directly observed therapy, abbreviated as DOT, as the best way to assure completion of appropriate therapy. Close monitoring of patients in the intensive care unit is more important than in other inpatient or outpatient settings. Especially in non-responsive patients in critical care, it is important to co-administer vitamin B6, that is pyridoxine, with isoniazid therapy in order to avoid isoniazid neuropathy. Isoniazid can also cause liver toxicity and cytopenias, which may be synergistic with other toxicities or comorbidities in critically ill patients. Rifampin is a strong inducer of cytochrome P450 metabolism. It is imperative to review all other drugs in patients on rifampin in order to anticipate potentially serious drug-drug interactions. Hypersensitivity reactions, such as fever and rash, and liver toxicity are other important side effects that require constant monitoring, especially in critically ill patients. Ethambutol can cause irreversible optic neuritis. Next we will discuss adjunctive therapy. Let's begin with corticosteroids. Several randomized controlled trials and reviews have addressed the role of corticosteroids in patients with various forms of extrapulmonary TB, such as TB meningitis, pericardial TB, and pleural TB. No study has specifically evaluated the role of adjunct corticosteroid treatment in patients with miliary TB. Current recommendations are based on limited evidence, further hampered by conflicting results. A beneficial response was observed in some studies, but not in others. Presence of associated adrenal insufficiency is an absolute indication for corticosteroid use. Adjunctive corticosteroid treatment may be beneficial in miliary TB with TB meningitis, large pericardial or pleural effusion, immune reconstitution disease, ARDS, immune complex nephritis, and histiocytic phagocytosis. Recent reviews have summarized the evidence for adjunctive corticosteroids in the treatment of tuberculosis, pericarditis, meningitis, and pleural effusion. These reviews have shown improved mortality for patients with pericarditis and meningitis. While clinical parameters improved more rapidly in patients with pleural effusion, steroids were not associated with any lasting improved outcomes for such patients. Next we will discuss drotrocogon alpha. Only one case report using activated drotrocogon alpha in miliary TB is available in the literature. Decisions to use this compound will have to be based on generally approved indications for this treatment adjunct. We will now look at supportive therapy. Patients with miliary TB often behave like patients in septic shock. Treatment can further paradoxically worsen the intense cytokine release and the associated multi-organ failure, either through release of intracellular antigens from dying tubercle bacteria or reversal of TB-induced immunosuppression causing immune reconstitution disease. Treatment-induced side effects can aggravate comorbidities or drug effects commonly encountered in critically ill patients. Drug-drug interactions can be difficult to manage in patients on rifampin-containing regimen. Collectively, these patients tend to be complicated, at high risk for mortality, and therefore require intensive multidisciplinary supportive therapy. Finally, we will discuss prevention or infection control. Any significant suspicion of active pulmonary TB should prompt placement in an ARI room with negative pressure isolation. Patients should be educated about the purpose of such isolation and instructed to cover their nose and mouth when coughing or sneezing, even when in the room. If the patient must leave the room, a surgical mask must be worn. All other persons entering the room must use respiratory protection, usually an N95 mask. Doors must be kept closed and negative pressure should be verified daily. Anterooms are desirable, but not required. When present, the door to the anteroom and the door to the ARI room should not be opened simultaneously. There must be at least 6 air exchanges per hour. 12 or more exchanges per hour are preferred and are required for any renovation or new construction. Air should be exhausted to the exterior, removed from any intake vents. If recirculation to general ventilation is unavoidable, HEPA filters must be installed in the exhaust ducts. A patient may be transferred from an ARI room to another hospital room when he or she is being effectively treated for TB, is improving clinically, and 3 consecutive sputum samples, obtained on different days, are smear negative for AFB. For patients with initially negative AFB smears, at least 2 weeks of TB treatment should be administered before isolation is discontinued. If 3 additional specimens can be obtained at this time, they should all be AFB negative. Maintaining ARI isolation throughout hospitalization is strongly recommended for patients with MDR TB, cavitary lesions, or laryngeal TB. Most healthcare facilities have hospital-specific guidelines that should be consulted and followed. Thank you.